Yes. Buongiorno a tutti. Il mio italiano non è abbastanza buono per fare una presentazione, quindi continuerei in inglese. Sorry. So I will go on in English, and I have to say that I don't have any potential conflict of interest for this presentation. Just one, that I like a lot Italy, Milano, the people, and Italian food. So that may be a conflict of interest that I'm here. Let's see. It's always almost very hard, very difficult to be a speaker after Edmund Cohen, because he's always excellent, and he told a lot about what I'm going to say, and so somewhere my task is easy. You know that mechanical ventilation will cause generally too long mechanical ventilation, either on intensive care or during anesthesia. It will cause at one side biochemical injury, on the other side biophysical injury, and everything will lead to complications, to secretions of mediators, interleukins, so on, and finally to organ failure. So mechanical ventilation, either during a short period of anesthesia or during long-term intensive care ventilation, is non-physiological. Moreover, you know, one-lung ventilation, those who are, I suppose you are doing one-lung ventilation because you are here. You know that one-lung ventilation, the indications are very restricted nowadays. We are doing one-lung ventilation not because it's mandatory. We are doing it to help the surgeon, because if you are doing one-lung ventilation, the surgeon will have better access to the operating field, and he's operating much quickly, so it's better for the patient. You know, one lung is ventilated, the other one is not ventilated, but both lungs are perfused. So we are creating a shunt, and you know that if you are keeping the same constants during two-lung ventilation and during one-lung ventilation, this shunt, of course, will create a lower PaO2 and a higher alveolar arterial oxygen tension difference. I mean, lower PaO2, that doesn't mean necessarily hypoxemia. Everyone knows that there are a lot of mechanisms, either active or passive, that will try to influence this redistribution of blood perfusion to the non-ventilated lung. And active is the hypoxic pulmonary vasoconstriction. It was there were a lot of articles written over hypoxic pulmonary vasoconstriction a couple of decades ago. Just take a look at the literature. There's nothing anymore about hypoxic pulmonary vasoconstriction since at least 20 years in the literature. There are other mechanisms, passive mechanisms, like surgical manipulation. Surgeon is manipulating the operated lung, he's manipulating the vessel, and he's manipulating the blood flow. Gravity, thoracic surgery is most of time in lateral decubitus position. And of course, pre-existing lung disease. So of course, in clinical situation, we cannot isolate one or other factor to say that this will contribute so much or so much. Hypoxic pulmonary vasoconstriction, it was well described. You can find it back in any textbook. You know that hypoxic vasoconstriction will contribute to a diminishing almost of half of the blood flow to the non-ventilated lung. We can influence it, of course. We have a lot of anesthetic drugs who will either inhibit it or stimulate it. Vasodilators inhibit it, vasoconstrictors stimulate it very generally. Ventilatory methods, PEEP, high alveolar CO2, FiO2, and so on. But how can we predict that the patient will have hypoxemia during one-lung ventilation? What's hypoxemia, first of all? Hypoxemia is defined, most of authors are defining it as a saturation lower than 90%. I agree. let's say personally, I don't have much patients with such low saturations, but it's defined as lower than 90%. So we can predict it. And since a couple of years, there were studies analyzing it. Of course, one of the predictors is the site of operation. You know that the right lung is bigger than the left one, so that means that if you're ventilating the right lung, like during a left thoracotomy, the patient will desaturate less. He will have a better oxygenation than during right-sided operations. And it was shown, let's say 15 years ago, Schwarzkopf and Karzai, it's a German group, they showed that during one lung ventilation with an FiO2 of 100%, the patient's PaO2 diminished during one lung from 280 during during left-sided operation, right one lung ventilation, versus 170 during left-sided one lung ventilation. I ask you, 280 or 170 for me is no hypoxemia. It's less PaO2, but it's no hypoxemia. Peter Slinger has done a regression analysis of the site of surgery, and he showed too that the site is an important predictor. Of course, the lung function of the patients, paradoxically, patients with a less good lung function, I mean COPD patients, heavy smokers and so on, they will desaturate less than people with a good normal lung function, probably because of the chronic hyperinflation, chronic intrinsic PEEP that they develop, and they will have probably a better FRC in the ventilated lung. Of course, arterial blood gases, PaO2, if the PaO2 is good at the beginning of the operation or during two-lung ventilation, it will be better during one-lung ventilation too. Imagine a patient who has a room air PaO2 of 60, who needs to have one-lung ventilation. Of course, he will have a bad PaO2 during one-lung ventilation. The perfusion to the non-ventilated lung, another predictor. The higher the pre-op perfusion, the lower the PaO2 during one-lung ventilation. With other words, again, the German group studied patients, and they've seen that the higher lesion in a lung is, the less the perfusion that lung is already, so the perfusion is already reduced. So if they are doing one lung ventilation, the shunt will be not so huge at that lung. I mean, if they are doing pneumectomy for a huge tumor, it was 55%. Sorry, metastasectomy, it was 55%, lobectomy, it was 47%, and pneumectomy, it was 30 and something percent. So the bigger the lesion, the less the shunt is at that lung. A Japanese group showed that, you know, when the patient is in the supine position as compared to the lateral or semi-lateral position, the PaO2 will be better due to gravity in the lateral position. My group a couple of years ago showed too that there is an increase in PaO2 if you're one lung ventilating a patient in the lateral position as compared to the supine one at 3 different PaO2 levels. You can see here the increases at that time. Thereafter, we have done some non-physiological one lung ventilation, let's say, so we have ventilated the upper lung and deventilating the lower lung in healthy patients, and actually it showed that there is for sure a gravitational redistribution. Another problem that we know nowadays for hypoxemia, anemic patients will have an increased shunt fraction. That was first shown by Deem in rabbits, and thereafter our group has hemodiluted patients, and we have found that in COPD patients who were really lightly hemodiluted, the PaO2 diminished a lot as compared to normal lung function patients where the PaO2 remained constant, or to the control group. So let's see, over the decades, Edmund Cohen told you in the 70s, the occurrence of hypoxemia during one-lung ventilation was 25%. Thereafter, in 74-24, Slinger reported in 93 8%, Schwarzkopf in 2004 4%. Where are we now? At 1%, we have better anatomical physiological knowledge, better lung isolation material, routine use of fiber optic bronchoscope, new anesthetic drugs, better ventilatory techniques, or better surgeons. For sure, we have better surgeons too. Sometimes they are pushing too far. Let's say anesthesiology is something that who is following surgery. You know, that's a robotic surgery here. You see the famous Da Vinci robot. The surgeon is operating at his console. There is a resident at the table. But what's wrong with this image? You don't see any anesthesiologist, and the anesthesiologist is somewhere outside here. So we learn to improve preoperative chest lung function by chest physiotherapy, by bronchodilators, and nowadays I know that the group of Geneva, Mark Licker, is very busy with this topic, pre- and post-operative lung function in lung patients. I don't know, does anyone of you know who this guy is? He's written, is John Pacey. It used to be a vascular surgeon in Vancouver, British Columbia. It used to be because he's retired by now. Vascular surgeon. He's the guy who invented the famous glide scope. It was one of the first video laryngoscopes. So intubation for one lung ventilation, it was facilitated too. Nowadays, of course, we have a lot of huge types, a lot of brands of video laryngoscopes. You just have to choose one, so it will diminish the incidence of hypoxic events too. This is the Karlans tube. I won't speak about it, but you know, Karlans was a chest physician 70 years ago in Sweden, and he invented this tube and he put it in awake patients. Imagine, in awake patients, just to do bronchoscopy in these patients. So at the beginning, these tubes were used to lung separation. Nowadays we have, of course, modern double lumen tubes with less resistance, and of course disposable. So less resistance, that means better ventilatory conditions, less traumatic to the airways and so on. Of course, we have a lot of modern lung separation devices. From one of the first ones was the Univent and Fuji blockers. Thereafter was the AND blocker, and more recently the Cohen blocker and the Easy blocker. We have airway exchange catheters. We don't have to just to exchange an airway, a tube to a double lumen tube and vice versa. We have exchange catheters which increase security of the patients. And of course, from '67 we have the fiber optic bronchoscope. Now, you know, that was a study of the European Association of Cardiothoracic Anesthesiologists, and a survey a couple of years ago, 3 years ago, everyone responded, we are using fiber optic bronchoscope. So using fiber optic bronchoscope is not enough. You should know what are you doing with the fiber optic bronchoscope. If you have the fiber optic bronchoscope, you are looking with it, you should know what are you looking actually. So therefore there are, let's say, Edmund Cohen is not just the godfather of thoracic anesthesia, but he is the first who organized thoracic workshops, hands-on workshops to learn lung isolation devices and fiber optic bronchoscopy. But you have nowadays simulators, bronchoscopic simulators, you know, and that's a kind of hands-on training too. Something else that diminished too, incidence of hypoxemia, because that's a citation of a surgeon. It was Dr. Bell who said it, that yes, you anesthesiologist, you are oxygenating the patients with Ringer's lactate solution. You know, and thereafter you see, you obtain such images on the lung. Everyone knows, I think, from the very first year of residency that goal-directed fluid therapy or fluid restriction, but it's another topic. It's better than really liberal therapy. So, you know, when a surgeon is saying such thing, it's like a bomb, like an atomic bomb. It's exploding. So everyone, it's the anesthesiologist who is giving lactate to the patient. So we know it. We are trying to keep the patients in fluid restriction, and they will have a better oxygenation. So Edmond showed a similar image. You know, you'll find it back in every textbook, in every classical textbook of thoracic anesthesia. If one lung ventilation is not working, you should maintain two lung ventilation until pleural is opened. You should give 100% oxygen, tidal volumes 18, 12, PEEP respiratory rate to keep normocapnia, use total intravenous and so on. That's Edmond said is not the same thing today. No high FiO2, low tidal volume, PEEP, increased frequency, use sevoflurane, recruit, of course, and actually there are no differences. This is more a question of to be used pressure versus volume controlled. But we are more concerned nowadays with avoiding volo and barotrauma than hypoxemia. So, you know, unfortunately, there are still a lot of anesthesiologists who are using very huge tidal volumes, I mean 8, 10 ml tidal volumes during one lung ventilation. That's really huge. PEEP and CPAP, Edmond told you, we have devices to give CPAP at the non-ventilated lung, but sometimes it's really hard to give it when the surgeon is doing a non-invasive surgery. And I think, at least in my institution, I didn't see a real thoracotomy since a long time. Recruiting, it's good. It should be daily practice, but just take a look. Tussman recruited 15 patients. The lowest value here is something like 100 PaO2. PaO2 is still not hypoxemia. It's lower value than during two-lung ventilation, but it's not hypoxemia. Just one word before I finish. So I don't know if you read this article. These are the WHO, the World Health Organization, surgical site infection prevention guidelines. They're recommending to use, they're saying to use 80% oxygen during ventilation, during anesthesia and general anesthesia and ventilation, and of course one lung ventilation too. And let's say there are a lot of responses and letters to the editor. One of them is this one. It's from the World Federation of Societies, who is saying that 100% oxygen is not good. Something else, just that we have methods of visualizing ventilation and visualizing one lung ventilation. So it's a kind of, that's an electrical impedance tomography method. You're visualizing the ventilation if you have the machine, of course, and it's really nice. You can recruit under direct visualization. So, just to finish, hypoxemia decreased from 25, 24 in the 70s, thereafter 8%, thereafter 4%. I don't dare to say that we are at 0% today, but it's still a concern because it's still 1-2% for sure below the 5%. Just let me say, we are evaluating too, we are learning a lot, we have good materials, and that's why we had such a low value of hypoxemia. Thank you for your attention. That was Mert Sentürk, Edmund Cohen, Giorgio De Rocca, and I, a couple of years ago, searching for the golden Buddha, I think, in Thailand. No, it's Photoshop.
We have the abdominal muscle.
After that, yes, that's not fair.